So I really cannot be more pleased to introduce Rich Anderson. Rich and I served together on the Peds Section Executive Council for the past few years and have really partnered on reconfiguring the vision and mission of the section, how it can best serve the pediatric neurosurgery community. I can tell you there are really few that I've enjoyed working with as much, not just because he's an extremely nice guy, as you'll see, which he is, but because he really both is a brilliant thinker and communicator. His opinions are genuine. He delivers both good and bad news with great sensitivity. People don't get offended somehow. The section has really benefited immensely from him as significant changes were occurring. So I imagine that your patients must worship you, Rich. So Rich is currently clinical associate professor at NYU. He completed med school and residency at Columbia and did his fellowship in Utah, which remains one of our premier pediatric neurosurgery programs. He practiced at Columbia until 2020 when he moved to NYU. In the Peds section, Rich spent years building and managing the website. The website is what it is because of him. Now he's completing his service as secretary, and in April he'll be chair-elect. So academically, he received many honors and published extensively, especially on spine and tumors. Importantly, he built a reputation as a leader in complex spine surgery in children and figured out how to collaborate extensively with our pediatric orthopedic colleagues. So today he'll tell us a bit about the role of the pediatric neurosurgeon in this area. His only problem is he has no sense of humor, but no one's perfect. Maybe you can change it today. Thank you for coming.
Benny, thank you so much for a very, very kind introduction. Before we get started, I wanted to share my favorite story about Benny. So as he mentioned, we serve on the pediatric section leadership together, and we had a meeting down in Philadelphia, and Benny's got to be about the most easygoing guy any of us have ever met. So I had set up a lunch meeting for us, for Benny and I and a few other people. And it was down in Philadelphia where there's this amazing market there with hundreds and hundreds of food venues and so forth. But it's like a big city block. There are 10 different entrances. It's pure mayhem in there. So there's no possible way you can find a location to meet there. So I'm like, all right, Benny, we're going to meet at Panera across the street because it's a very easily localizable place. So we're all there, and then Benny strolls up. He's the last one to get there, and I'm like, "Hi, Benny," and Benny says, "Hi, Rich." And I may be paraphrasing this a little bit, but Benny essentially goes, "Rich, I'm happy to have lunch with you, but with all this great food across the street, there's no way in hell I'm eating at Panera." And so that was about the only time I've ever met with Benny where he's like, okay, it's my way or the highway this time, but every other time it's easy going, Benny. So anyway, but all kidding aside, it's really an honor to be invited to give grand rounds this morning. Let me get my slides up here and get us going here. So as Benny mentioned, most of my research interests and focus have been on pediatric spine. So I thought I would discuss a little bit about the guardians of the pediatric spine and where I think that pediatric spine research is going. So full disclaimer, in the interest of time, I'm going to focus this talk on the craniovertebral junction and cervical spine, just because it's too much to go through all the other stuff. We'll talk a little bit about where we've been and some of the giants have been and what we learned from them. We'll talk a little bit about where I think we are now, where should we go, and probably most importantly, how are we going to get there? So, in the 80s and 90s, the first couple decades, we're really focusing on understanding the craniovertebral junction and the cervical spine. And these two giants, Arnold Menezes here and Dakling Peng here were really some of the amazing leaders in this arena. We learned from them a significant amount about the developmental anatomy of the pediatric spine, the biomechanics, early pathologies, and even early outcomes in terms of stabilization. So if we look at Arnold Menezes, he taught us a tremendous understanding of the innumerable different types of pathologies that can affect the craniovertebral junction, including Chiari's, basilar invagination, Down syndrome, skeletal dysplasias, and so forth. It was Menezes that really, hammered into us the fundamentals of reducible or irreducible deformities at the craniovertebral junction and the importance of traction, which you can see, in an algorithm over here. He was one of the first ones to publish on the early techniques of surgery at the craniovertebral junction, including both anterior approaches with transoral techniques and posterior stabilizations, and published some of the very first studies on early outcomes, primarily using non-rigid or semi-rigid fixation. When we look at Dr. Pang, Pang's work was really focused more on the biomechanics of the pediatric spine. He focused on embryogenesis. The concept of skiwara, or spinal cord injury without radiographic abnormality, is really a pediatric disease where the flexibility of the spine permits, banging of the spinal cord without, complete disruption of the spine, and is really unique to pediatrics. He's done amazing work on atlantoaxial rotatory subluxation and understanding the biomechanics of rotation at that joint, as well as the, defining and seminal work now on atlanto-occipital dislocation and understanding, looking at the CCI, the joint there, and that 4 millimeter rule about whether you really have atlantoaxial dislocation or not. In the next couple decades, we moved away from just trying to understand the pathologies to really focus on rigid instrumentation. And these guys here, Atul Goel and Sandeep Chatterjee in India, and Doug Brockmeyer, who many of you know, really focused on the techniques of rigid instrumentation, whether it's technically feasible to use adult-sized screws and rods and so forth in children, and really applying the adult techniques in children, and then publishing some of the early seminal work on outcomes of using rigid instrumentation in children. So Doug was the first one really to popularize transarticular screws in young children. Trying to apply all the different screw techniques, whether it's, pedicle screws, par screws, laminar screws, or transarticular screws, at C1, C2, or at the craniovertebral junction. Did some early work on occipital cervical constructs, but really focused on the early instrumentation. Here's a study that we all put together looking at, this is the largest series of rigid instrumentation in kids, focusing on whether you had to put instrumentation in C1 when you're doing O2 fusions. And this is one of the first studies that really showed us that with rigid instrumentation, you had a significantly higher fusion rate, with nearly 100% fusion rate, with minimizing the use of halo vests, which are definitely one of the most barbaric things we've ever invented in children, with low complications overall. And these techniques can be used in younger and younger children. Here's a table here from a few years ago, demonstrating that you can use these techniques and all these different types of screw types in younger and younger children, down to about 1.5 years, and subaxial lateral mass screws even now down to about 3 years of age. As long as you think about it carefully and study the CT scan and make sure it's technically feasible to put those types of screws in. So where are we now? So we've made some technical advances now, and we started with low-hanging fruit. So again, adapting from the adult guys, we've started, going through the nose instead of going through the mouth for simple procedures like, odontoidectomies for those rare cases where ventral decompression is necessary. And we've started with just even low-hanging fruit. So, when you're a spine surgeon, one of the most important things is what type of bone graft you're going to use. And surprisingly, it's not absolutely clear whether using your own bone or using, allograft is the right way to go in children under different circumstances. So we've asked this as a fundamental question. And when we look at autograft versus allograft, we first look at C1, C2, and that's better defined. We started out looking at a insurance cross-sectional database of children across the country with insurance database to try to see whether using for C1, C2 fusions, whether structural autograft or structural allograft or just bone chips of any type would be most beneficial and improve fusion rates. And when you look at that, even with the cross-sectional database where you're thinking of large numbers, the numbers whittle down, and the fusion rate was about 90%. So it's about 11% failure rate. But those numbers aren't big enough to get meaningful data. So we put our efforts together, and Doug Brockmeyer led this great multi-center study where we get all of the people around the country to put data together. We got many more patients. Interestingly, the failure rate for fusion was exactly the same at 11%. But it's with studies like this that we learned that when we look at age, unilateral instrumentation, what type of bone graft or anything like that, none of those made any difference in terms of risks for fusion failure. The only thing that turned out to be an independent risk factor for fusion failure was Down syndrome, that you can see here. So allograft versus autograft didn't make any difference when it came to C1, C2 fusion in children, perhaps because the overall fusion rate is so much higher in children. Well, what about O2? That's the most common instrumentation procedure we do in children at this level. Going back to the cross-sectional database, with a limited number of patients, the failure rate was higher. It was almost 20% failure rate in terms of fusion. So, but again, these numbers aren't high. So we need to get a multi-center study looking at that, but there is none. Because the most common single procedure that we do as pediatric spine surgeons in the cervical spine, there's never been a multi-center trial looking at fusion outcomes or risk for fusion failure. So we started with this in mind. We started a multi-center collaborative study, which is in process now, and we're gathering the data now together with orthopedics to have the biggest and highest quality study that we can look at. So once we started looking at kind of low-hanging fruit, the next arrow was we started looking at the consequences of instrumentation and fusion on the growing spine. We want to look at growth, because when parents come to your office and you're talking about putting screws and rods in, one of the questions they ask is, well, how does this affect the growth of the spine? So we started out by looking at the craniovertebral junction, and we found when we looked at these kids undergoing C1, C2 studies and O2 studies, that there's actually near normal growth of the spine in the cervical spine, even when you do these procedures, which is kind of counterintuitive, because when you do a AIS case and you're fusing from T4 to T12, we know there's not growth over that rigid construct, but no one's ever looked at that in the cervical spine. So we studied this, and at C1, C2, after almost 5 years of follow-up, an average of 31% of the entire growth of the spine, of the cervical spine, occurred within the construct. And how can that be so? Well, it probably has to do with remodeling. You're only fusing one level, and so you get remodeling of the bone above and below the construct that still permits vertical growth. And importantly, the alignment stayed good. There was virtually no adjacent segment disease, although it's early follow-up. It's only 5 years. It's not 25 years. But overall, they did well. Well, what about O2? Well, surprisingly there, 78% had growth within the construct. There were a subpopulation, about 20%, that had no growth within the construct, but we didn't have the granularity to try to figure out why that, what were the risk factors for that group. Very few of these kids, there was a lot of worry that these kids would all develop crankshaft and they would have hyperlordosis problems if you fuse the occiput to the cervical spine too early. But we didn't see that. Unintended fusion, saddle balance problems, adjacent segment disease, again, were all very rare. So interestingly, you notice when I discussed that, I talked about percentage of growth within the cervical spine as opposed to comparison to normal growth. Because while we were doing that study, we combed the literature and realized that no one had ever done a study looking at what normal growth of the cervical spine was. So I leaned on buddy Cormac Maher out at Michigan to do, to mine the database, the Michigan database with all those CT scans and MRIs, and do a cross-sectional analysis looking at growth of the cervical spine in kids. We've known from Dackling Pang's work that biomechanically, the cervical spine becomes more like an adult spine around 9 or 10 years of age, but nobody had any idea when anatomical maturity occurred. So looking at this study, we now know that for young women, the cervical spine stops growing at about 12 years of age, it plateaus off. And for young men, it stops growing at about 15 years of age. So although a simple study to do, no one had done it before. And this allowed us then to look at the subaxial spine. And what we found with the subaxial spine, since the study was done later, was we could compare the growth when you do 2-level, 3-level, or 4-level fusions in the subaxial spine, how that affected growth compared to what normal growth should be. And as you might expect, so these are 2-level fusions, 3 and 4-level fusions, and the red line is what the normal growth would be in terms of length of follow-up and growth. And you see that when you do 2-level fusions, the slope of that line is essentially the same as the slope of the normal growth. So again, there's probably remodeling above and below to allow that growth without really affecting the growth of the spine. Even with 3-level, you've got that very close slope line, but only when you're going to 4-level fusions do you see that slope of that line really dropping off, understanding that we are affecting vertical growth of the cervical spine when we're doing these constructs. Interestingly, though, because the width of the spinal canal is essentially fully grown by about 4 years of age, the vast majority of the time you're doing these fusions, it doesn't affect space for the cord or the diameter of the spinal column, at least for the cord. So we established normals, we looked at growth constructs, and then one of the other things that we had to look at are these really horrific deformities where we have to do instrumentation and fusion all the way from the occipital region all the way down into the cervical and thoracic spine. And these are amazing things. This is a young kid that I was taking care of with spondyloepiphyseal dysplasia, following him since birth. He's got a horrific deformity like this. But when they're that young, you just can't fit any rigid instrumentation. So you stall on these kids as long as possible. You brace them as long as possible. But unfortunately, she started, developing signs of myelopathy, so I had to do something. So I put her in traction, stretch her out. And then the bones here, it's like a bag of bones. There's no identifiable bone that you can put screws into that young. I had to operate on her at about a year of age. So I had to instrument up into the occiput where you can actually get some bone in, and then down into the thoracic spine where you can put some small pedicle screws in. And this girl did great. She's 7-8 years out now, and her spine looks good. She's got a nice solid fusion in the back, and she's up and running around, and she's doing great. But it doesn't always work that way. Here's another kid with Loeys-Dietz syndrome, a similar type of problem, almost like a dislocation here, and a little bit different because it's more like a dislocation as opposed to a swan neck deformity. And this kid was a little bit older. This kid was about 3 years of age. And so similar technique, and he was already starting to get myelopathic. So I'm like, same kind of thing, put him in traction, stretch him up. Here's the immediate post-operative X-ray, and I'm, slapping high fives to my, residents. We're like, this is a great, radiographic outcome. This is a home run. This kid's going to do great. And clinically he's doing great. Then he comes back a year later, and this is what his X-ray looks like. So I just want to draw this to your attention. Here's the dens right here, and here's C3. So how this slipped off and went anterior to the spine is something that I don't know the answer to, but something that we need to study more and try to understand why this type of happens. And I think in this case, it probably had to do with, because of this location, there was no anterior longitudinal ligament at all. So any restriction of growth in the back, and there's growth in the front, probably made that fall off, but that's a discussion for another time. So for this, we need to do better. So we put together a multi-center collaborative study. These cases are rare. We only had 13 patients, but they all had severe deformities like this, all requiring, multiple procedures, many with traction and that kind of stuff. And we published this study, probably 10 years ago now. Oh yeah, there we go, 2011. So a little over that. And when I talked to the authors who contributed patients to this study, over half of these kids have had to go back for more extensive surgery and taking out these constructs, doing anterior surgery or XYZ. So we need to do better than a 50% complication rate and redo rate for these types of things. So one of the ideas that we had, it's a baby step, but it's something what we call temporary occipital fixation. So when you look at a case like this, which is another 3-year-old kid who had a spinal dislocation, the problem is here. right? But again, when you're doing when you're taking out 3 levels of the bone, you're destabilizing this bone, the spine so significantly that a few lateral mass screws above that is no way is that going to hold the spine. You've got to have more fixation. So you have to go to the occiput. But there's nothing intrinsically fundamentally wrong about the joint at the occiput in this case. So what we did is we put them in traction and did an anterior posterior approach, did the 3-level corpectomy to decompress the cord and everything, and attached to the occiput. But we only laid bone graft down here where the problem was. We didn't lay bone graft down at the occiput. And then we bring them back a year later after a CT scan shows that this is all fused, and then we disconnect the occiput. Now, I know what you guys are all thinking. You're like, okay, Anderson, that's still a lot of metal in there. And what's the big deal, taking that off? But remember that biomechanically, about 40% of the motion of the neck, an axial rotation flexion is from C1, is from the occiput to C2. So when you can restore about 40% of the motion of the neck, that's probably something worth considering. So, but again, we need to do better. There've got to be better ideas than that. And one of the things I learned from, my orthopedic colleagues is that, you can't fuse the spine, the thoracic spine, in a 4-year-old kid, because then it doesn't grow and the lungs don't grow. And ultimately the children get bigger, but their lungs don't get bigger, and they ultimately die a pulmonary death. And so they have to do growing rod constructs in these kids where they, put constructs in that allow growth to continue to distract and expand the spine to allow their kids to grow if they have to put instrumentation in. But these are things that are amazing, and they have a magic now where it's magnetically controlled, where you can control with a magnet and expand it. But the problem is these are way too big for the cervical spine in young kids. So the question that a lot of us are asking is, could we use some type of Schiller system? And a Schiller system is where you've got a rod, a screw and rod construct. And usually, as all of you guys know, we put the cap down and lock that rod in place so things can't move. But a Schiller system is where a cap goes on, but the rod is not locked in place. So it allows the rod to slide. And a Schiller has been used in the thoracic, spine for, quite a long time. But you can see how there's this space here. It doesn't latch onto the rod. So the question is whether we could put a Schiller system or something like it in kids, lock it to the occiput in some of those examples that I showed, but leave the rod long at the bottom to allow the rod to slide and allow growth of the cervical spine, in these, really interesting and unusual cases. So where are we now? So what we need to do now, I think, is that we need to do a better job at understanding indications for stabilization of the craniovertebral junction. So when it comes to trauma, we have a pretty good understanding. Like I mentioned, Dr. Ling Pong has done amazing work. We all know that when a kid comes in with a potential atlanto-occipital dislocation, we need to look right at the joint. We need to do a CT scan and look at the CCI, or the condylo C1 interval. And we know that it's like a spring. And once that spring is sprung or opened, then it doesn't go back. And if that CCI is greater than 4 millimeters, that is a very, very high correlation with atlanto-occipital dislocation and instability. When it comes to C1, C2 algorithms, we, again from Dr. Ling Pong, we have a very good understanding that the vast majority of rotatory subluxation, gets better with muscle relaxants or a brace or halter traction. And only if that doesn't work down the road do you have to stabilize these kids, or if it's a chronic situation. But when it comes to congenital and syndromic problems, it's much, much more difficult. So Chiari is a great example. So Doug Brockmeyer has done amazing work looking at complex Chiari and these small subset of children that come in with more complex Chiaris and have a much higher risk for craniovertebral instability. Now, to be clear, the vast majority of kids that come in with Chiari malformation do not fall into this category and have simple decompressions and do very, very well. But there is a subset, that have a much higher risk for instability. And we're trying to figure out which of these children need fusions and stabilizations up front, or which of these fusions which of these children are going to fail down the road and need fusions down the road. And there are some craniometrics we look at, like the CXA and the PVC2, but it's a lot of it to do, and what Doug's studies have shown is it has a lot to do with symptoms and whether they really have bulbar symptoms that make it much more likely they're going to fail. But we need to do better with this. And what I really want to do is work together with people to develop, similar to an ETV success score. I want a risk for craniovertebral junction instability score. I want a system where we've got a score here, we've got the age of the patient, we've got the etiology, maybe whether it's a complex Chiari, maybe what their craniometric, measurements on an MRI look like, what their CXA is, what their PVC2 is, maybe whether they have, some other type of, in a column with clinical symptoms, whether they have bulbar symptoms, no bulbar symptoms. And then I want to be able to come up with a score saying, okay, in your situation, there is a 70% chance that, you're going to develop instability and need a fusion or not. So this is a big area of research that I think we need to go into and really do a lot of work for the cervical spine. The other things we need to do is we need to understand the biomechanics of the cervical spine better. Why is it that we can have a bowling ball on top of, the C1 and C2, lock that in place as one biomechanical unit, and the stress on that C2, C3 joint, has got to be intense, and we don't have a way to measure that. But why is it that now, 15 years out, I've never seen a single case, and I don't know if I've ever seen other people or it's published about adjacent segment disease in kids at the C2-3 level. Why isn't this all breaking down? And maybe it's because we don't have long enough follow-up. Maybe it's, 30 or 40 year follow-up that we need. But maybe it's because the biomechanics change and the fulcrum of, biomechanical forces move down to C4-5 like an adult soon enough that it takes somehow a lot of biomechanical pressure off this, and these kids are going to be okay. I don't know the answer, but that's something that we definitely need to follow up with. So, to kind of getting towards the conclusion, one of the most important things I've learned from Benny over the last few years is not just what you want to do, but you got to have a plan for how you're going to get there. And the plan to get there, I feel strongly, is with collaboration and recruiting people to join in a collaborative society. So for the residents that are listening and the fellows and so forth, there's only one thing I want you to remember from this talk. And that's this line right here, that the days of single center studies are over, okay? Nobody cares how 50 kids that Rich Anderson did an OC fusion on do 10 years later. Nobody cares about that. What people care about is how 500 kids with OC fusions did across the world or internationally or across the United States, and how they did 10 years out. Okay, so this is where the future is. We have to really move towards multi-center, interdisciplinary, international registries, and many, many of you are already involved in these kind of studies. But with pediatric spine, we're getting there. So, for instance, 10 years ago, we had multiple competing societies. So we as pediatric neurosurgeons founded the Pediatric Craniocervical Society. It was all pediatric neurosurgeons. We were all together. We would meet at the ped section meeting every year. We started a registry, a REDCap, a data registry. We had a couple hundred patients in that. A similar society in India, the Craniovertebral Junction and Spine Society existed. And then speaking with the orthopedic surgeons, there's a small group they had called the Pediatric Cervical Spine Working Group. Everybody was trying to do the same thing in silos, not working together. And so Doug Brockmeyer and I have made a big push to really get more involved with the orthopedic societies, because they have an amazing, amazing organization called the Pediatric Spine Foundation. And the Pediatric Spine Foundation has a database already with over 11,000 patients, unique patients in the database. It's combined orthopedics and neuro. These are all pediatric spine patients. It's an international registry. The budget is over $1.5 million annually. And there are about 100 members from, all these sites all over the world. And people from these sites, when they have pediatric spine patients, they put them in the registry. It's operative, it's non-operative. And each year we go, I blew it. Sorry. So each year we go to these meetings to collaborate with these people, and they have been so generous and so kind. And they're like, look, we realize the future of pediatric spine research is together with neurosurgeons. We want you in our leadership, and we want neurosurgeons to join the society and contribute patients. And the infrastructure is already there. So I contribute my patients there. They have a whole cervical spine rig. So any pediatric neurosurgeon in the country that does a cervical spine case can get on this IRB and submit patients to this. And this is what is going to allow us to do this collaborative research to answer these types of questions that we've raised and talked about a little bit today. So, I kind of blew it, but back to the initial, title of the talk. The question is, there have been a lot of guardians of the pediatric spine, but if we look to the guardians of the galaxy and we ask them what they would have to say about how we're going to get there, I think it's pretty clear what they would say.
For the guardians of the galaxy.
So for your movie fans, I think the Guardians of the Galaxy would say the only way to get there is by working together. So thank you so much for your attention. I'll stop the slides here.
Thank you, Rich. Wonderful. Do we have questions? Andy?
Yeah, thank you. That was outstanding. Really appreciate not only hearing your thoughts on where we are and where we're going, but also it's nice for the residents to hear somebody get an example of at least somebody reasonable who does ped spine type stuff. It's good for them to see occasionally. You talked about collaboration with orthopedics in the research setting. That obviously flows a lot from also working with them clinically as well, and getting ideas, as you mentioned, with the Shilla system, et cetera. How do you have advice for the residents? We have a good system here. Frankly, I have to give a lot of credit to Benny for fostering friendships, and that's been great here. But for residents, especially going out into practice, have you find what works, what doesn't work if you don't have Benny shepherding you?
Yeah, no, that's true. Not all of us have Benny to lead the way. It's a great question, and it's not one pathway is probably going to work for everybody, because all politics are local, as you know. But I do strongly believe that any pediatric neurosurgeon that wants to have a big role in spine has to collaborate with orthopedics. And the reason for that is because for 50 years, pediatricians, when they've seen a kid with a spine problem, scoliosis, XYZ, they refer to orthopedic surgeons. Okay, you could be the greatest pediatric neurosurgeon in the world, spine surgeon in the world, but you're not going to break through 50 years of referral patterns unless you are in an extraordinarily unique environment where there's no capable pediatric orthopedic surgeon that does spine. So in terms of just, business model and, the business side of it, working together with orthopedics, you are going to do far more spine than you will if you try to compete against them. But the most importantly, it's just so much more fun to work together with them. When you have these high stressful cases where you're doing 3-column osteotomies and the spine's unstable and you're losing signals in the OR, having another experienced spine surgeon there talking about, okay, well, let's jack up the blood pressure. What do you think about this? And because we have checklists for that, but there's a lot of thinking at the moment. Do I compress this rod? Do I flip the rod to the other side? What do I do to try it? Because it's a race against time. The spinal cord is ischemic, and you're trying to make these decisions quickly and effectively and systematically, and having another person there doing that together with you is amazing. And neurosurgeons are value added to the table. I can't tell you the number of times that, from working with multiple different orthopedists, where I'll go in and do something and they'll be like, "Oh, Rich, I would never do that. I would never be comfortable doing that." Neurosurgeons are value added. The training that all of you, will have coming out of that, such a tremendous program. You guys are going to be, so far ahead of the game, and you guys will, really be value added. But, again, as Andy and, Benny said, it's a way to approach it. You don't walk up to an orthopedic surgeon and be like, "Yeah, you're going to be lucky to have me on the other side of the table from you, and I'm a gift in your operating room." And it's not like that. And to be fair, that they'll learn a lot from you, but I've learned so much from the orthopedic surgeons too. So it's really a wonderful collaboration, because of the different skill sets and mindsets that come together to give the best outcomes for these kids.
Somewhat maybe building on that point a little bit, but pivoting also, is the question that I had is, they are coming from a different perspective and training background, and kind of this historical context. And especially as you're developing a clinical program, and if you focus just on clinical protocols, you mentioned kind of checklists in the ORs, and how you approach preoperative or perioperative management, protocol development, and engaging with them, especially in an area where these are kind of rare problems and without much data. How do you reach that consensus, or where do you draw that from?
Yeah, so probably the single most important thing you can do that I recommend, is to have a pediatric spine indications conference. It's a multidisciplinary conference. So, for instance, we had that at Columbia with Mike Vitale, and when Larry Lanke came and so forth, and we would have that every week, and we'd talk about cases all the time. And that's where you've got multiple surgeons, chiming in. In general, I think, decisions are better made in groups than individually when it comes to complex things like this. And so hearing other people's opinions on it, really makes sense. When I went to NYU, they didn't have a dedicated pediatric spine indications conference. They basically had an adult conference. And you've got to, if you want to do pediatric spine, you've got to pull it off into a separate conference, because the people who are really interested in doing pediatric spine want to talk about pediatric cases. And there's so many adult cases that the pediatrics gets pushed to the side. It's great to invite the adult spine surgeons, because they often will have wonderful ideas and be really helpful in these complex situations. But the way that those clinical pathways and algorithms and traction protocols and postoperative protocols and risk prevention, SSI prevention, all those things are developed was through those, collaborations with indications conference every week.
That's great.
Rich, this is great. Just two quick questions. That one is advice for the residents. Neurosurgery has become an overwhelming field. I mean, lots of specialties, subspecialties, subspecialties. How do they navigate their decision making during residency? And the second, in line with what you were saying before about orthopedics, the key is to really find where the complementarity is, right? So where, in your opinion, is the skill of the neurosurgeon versus the skill of the orthopedic surgeon in terms of their training?
Yeah, it's great. Let me tackle the second one first. So it's a great point. So, for instance, very few orthopedic surgeons are going to come to you as a neurosurgeon and say, "Look, I really need your help doing an idiopathic adolescent scoliosis case," because that's bread and butter, pediatric orthopedic spine. They are very capable of doing those surgeries completely independently, and they're very, very good at it. And there's, if you're on the other side of the table, they're going to get that case done faster, and it'll go smoother. And there are studies that show that there's less blood loss, there's less bleeding, less transfusions, less infection rate, lower complication rates, better correction when you have, two experienced spine surgeons working together, as opposed to, just one, and so forth. But the The real complementary skill set is with the more complex stuff. So that's the way I started with the orthopedic surgeons, is when you're doing 3-column osteotomies, when you're doing hemivertebrae resections, when you're doing anything that crosses the cervical thoracic junction and goes up into the neck, because the orthopedic surgeons are usually much less familiar or comfortable with placing screws in the cervical spine, whereas that's something that we as neurosurgeons do very frequently. And cases that you might think of, like spondylolisthesis cases. So a high-grade spondylolisthesis case is something that the orthopedic surgeons have historically only been in the wheelhouse of orthopedic surgeons. So, I mean, our adult spine surgeons do spondylolisthesis all the time, but it's, with degenerative, it's usually grade 1s, grades 2, and so forth. With kids, you're talking about, high grade, grade 3, grade 4, or spondyloliptosis. And one of the hardest things about those cases, the highest risk, is finding that L5 nerve root, because it is so tucked down in there. And we expose it, on this case when they invited me to help them out with one of these cases. And, we go in there and we're putting in screws and so forth. Then it's time to do the decompression, which, we have a lot of experience with as neurosurgeons. And then we go to find the nerve root. And, my buddy, awesome guy, Mike, he's kind of ditzing around there, and there's fat there and doesn't know exactly where to look. I get in there with the bipolar, start melting away all that fat, and I'm down finding that nerve root. He's like, I would never do that. I would never know that I can use the bipolar that close to a nerve root and so forth down there. And so then we do that. And then the T-lift, most pediatric orthopedic surgeons are not very familiar or comfortable or facile doing T-lifts. Whereas as neurosurgery residents, you guys do T-lifts all the time. So those are just some of the cases I think are the most value added. And then you build on that, and then they realize, oh, having you on the other side of the table, everything goes smoothly and it's a lot more fun. And hey, why don't you come in and help me with my AAS case? Because then I'm going to be done at 11 o'clock as opposed to being done at 2 o'clock.
Mhm.
So in terms of advice on what to do, I mean, people like Andy and Benny and I are very biased. We think pediatrics is the greatest thing ever. It's the wonderful thing about pediatrics is that you get to do everything. I mean, literally, one day you're putting screws in the spine, the next day you're taking out a brain tumor, the next day you're putting an endoscope in the brain. It's just absolutely amazing. And I could go on forever about this, but I'll tell you one last quick story about Columbia. So when, it was kind of tradition where the chief resident their last month would come over to the ped side to pick off one really super sweet case before they finish their residency. So chief resident comes over, and this is a guy that's going into spine. And we have another spine surgeon who's very famous, or infamous for being very brusque and to the point, and less sensitive than we are on the ped side, we could say. And so this resident comes over, we're doing this case, and everything goes beautifully. Everyone has a great time. And we're closing up, and I'm like, so you got everything lined up? He's like, yeah. And I'm like, it's never too late to do pediatrics. Pediatrics is the best thing ever. And, it's never too late. And he kind of puts his head down. He's like, oh, that's nice that you said that, Dr. Anderson. But that's not what my other attending said. I'm like, well, what are you talking about? He's like, well, I was doing a spine case with him the other day, and at the end he goes, it's never too late to quit. So it's a little bit, but pediatrics is the best, So if you have a heart into it, if you don't mind the parents, parents can be tough, but it's patience. But most importantly, you got to do what you love, whether it's vascular, spine, tumor. You just got to do what you love. It's the most important thing.
Thanks, Rich. Thank you very much. It's been a pleasure. Thank you, Benny, for bringing Rich here. Take care.
Rich,
Thank you so
thanks.
much, everybody.
Thank you.
Okay, bye-bye now.